All right. Good evening, everybody. Thank you so much for coming this evening to examining Babesia with Dr. Joseph Burrascano. This is actually a second part in a two, potentially more part series examining different types of tick-borne diseases. The last one was examining Bartonella, and now we're examining Babesiosis with the very well-known Dr. Joseph Burrascano. He is a well-recognized specialist in the diagnosis and treatment of Lyme and associated complex infectious diseases. With over 2 decades of experience and research in the field, he has appeared in and on virtually every form of media, has advised the CDC and NIH, testified before the U.S. Senate and Armed Service Joint Subcommittee, and at various governors' councils. As a founding member of ILADS, he is currently an active board member there, as well as on the International Lyme and Associated Diseases Educational Foundation, which is still associated with ILADS, but just a slightly separate entity. So again, today we'll be discussing babesiosis, which is a disease caused by microscopic parasites that can infect your red blood cells. And the main way that patients may get this disease is through a tick bite, obviously, given that we're talking about tick-borne diseases here. So thanks again, Dr. Burrascano, for being a speaker with us tonight, and I'll go ahead and turn it over to you. You should be able to share your screen whenever you're ready.
Well, thank you very much, Noah. It's my pleasure to come back. Let me start sharing the screen. Can you see that yet or no?
Not yet.
All right, we'll do the sharing screen.
Okay, perfect.
All right, let me get this. All right, look at that. Here we go. Bring it up full size. Minimize us. All right. Technicals, but here we are. Okay, so tonight I'm going to talk about Babesia, both the clinical diagnosis as well as some hints on management. As you'll find out, management is not clear-cut with this, actually, nor is diagnosis. So we'll get started. At the end, I believe we're going to be having some Q&A, and hopefully I can answer questions that have not already been addressed, well, by then anyway. So I always talk about Lyme, about Lyme having co-infections, and what I have coined is a phrase that ticks are nature's dirty needle. I mean, they bite many different wild animals. You can see in the picture, the deer, birds, reptiles, and to think they pick up one bacterium, one infection is silly. Of course, it can pick up a lot of things, and Babesia is one of them. So that's where this whole concept of co-infections come in. Specifically with Babesia, it may be the most common co-infection in Lyme patients, although it can occur by itself without Lyme being present. A serosurvey on Long Island, New York, found 66% of Lyme patients were seropositive for Babesia microti. IGeneX did a survey of over 10,000 samples, a variety of tests that they performed. And the most common were Babesia, 37 and almost 37.5%, more so than Lyme itself. Although if you combine the two Borrelia, Lyme and relapsing fever, then the Borrelia come out number one, Babesia two. Regardless of the fact that there are these different co-infections, the point is Babesia is common and you have to think about it. And because it can be subtle, it can be missed. Okay, so really consider Babesia in your Lyme patients. We know that co-infections are a problem, but why is that? Well, Babesia, especially if you have Lyme and the other tick-borne diseases and Babesia is present, those patients tend to be much more sick, more treatment resistant, and difficult to manage. The problem is that the symptoms often overlap with the other tick-borne diseases, so diagnosis is not always certain. But it's important because treatment regimens for the bacterial infections like Borrelia and Bartonella and so forth are different than the treatment regimens for Babesia. Babesia are not bacteria, they're protozoans, so it's a whole different ballgame. And despite that, or in addition to that, treatment resistance and treatment failures are actually common in Lyme. And why is that? Well, it's hard to treat Lyme, but maybe Babesia or some other co-infections present you didn't recognize, and maybe that's why treatment's not going so well. Babesia itself is a parasite. It lives within the red blood cells. It's transmitted by the same tick that can transmit Borrelia. It's noted for fevers, sweats, migraine-like headaches, air hunger and cough, profound fatigue, balance issues, and cognitive dysfunction. This is what you note, especially in the Babesia patient. Of course, there are many other general symptoms that do overlap with Lyme, but one important distinction is Babesia does not cause arthritis. Worldwide distribution, where they look for it, they find it. The map on the left is from IGeneX. It just shows the counties where they've received positive results on Babesia testing. So that's not exhaustive. Obviously, there are other labs doing Babesia testing. IGeneX doesn't test every American. So point is, it's present in every state, all 50 states, including Alaska and Hawaii. And worldwide, again, where they look for it, they find it. The blanks on the map are where they haven't looked. And basically, anywhere they did look, it's there. Okay, so think about it. Many different species. Microti and Duncani, also known as WA1, are the predominant ones in the United States, but there are other ones that are being found. There's one called CA type, California type, MO1 from Missouri. There's another unclassified one from Tennessee. Also, there's divergens and oticolii being found. IGeneX discovered there's a new Babesia-like species being found. It's giving strange results on their blood testing, which we'll talk about in a second, but they think it's a subspecies of microti, and it's being analyzed now. There are other species overseas, and that's important because people travel, the pets travel, livestock move around, and these things are being seen in America as well. I want to take a second to talk about Babesia oticolii because it's kind of controversial right now. It is found in many, many ticks across North America. It's the predominant Babesia species in deer. And the question is, are people getting it? Well, there are published case reports of at least 2 cases found in Canadian patients, some in America probably as well. And if you do IFA staining of the blood or of tissues, you can find Babesia that stains specifically with IFA staining specific for Babesia oticolii. However, if you do DNA sequencing, and that's been done, IGeneX sequenced 460 cases of Babesia, and not any single one was oticolii. So they don't think there's any oticolii, but other labs who do IFA staining think that there is, as do some clinicians. Why is that? First of all, when you do DNA PCR, you're not doing an analysis, or I'm saying with sequencing especially, you're not doing an analysis of the whole genome, just certain primer sets, so maybe you're not choosing the right one. On the other hand, IFAs are known for the non-specificity, and maybe it's just not such a great IFA. But on the other hand, if you do an immunoblot, and we'll talk about that later, it's a serologic test that looks for different species. You'll see microti, you'll see Duncani, but you'll see a lot that are neither one. And what are they? Divergens, oticolii? Nobody knows yet. So the jury is out. Whether it's important to know that this is there or not, we don't know yet. We don't know if this is more difficult to treat, if it causes different clinical pictures, or if it's not even there. I mean, the jury's still out, but I just wanted to mention it. So Babesia enter the red blood cells where they multiply, or they divide, and then they escape into the bloodstream and then find another red cell to infect. So therefore, it's a red cell parasite. But in cases of very high infection rates, you will see free-swimming Babesia in the bloodstream. And if you do see that on blood smears, then you know you have an especially difficult case to deal with. How sick the person gets depends on the person and on the parasite. So from the person's point of view, has to do with the immune response, obviously, but also with the character of their red cell membranes, because the Babesia have to recognize and bind to the membrane before they can invade. So depending on the host membranes, that might be a factor in how susceptible the person is to Babesia. Likewise, the strain of Babesia that infected the person may not match up so well with the membrane, or may match up terrifically well. And that's why some cases are really severe. Other cases are so mild that the infection is not even thought about. But when the infection is present, as you can imagine, the inflammatory cytokines go up, but there are also vascular cell adhesion molecules that are upregulated. In addition, as we know, red cells are larger in diameter than the capillaries they're supposed to flow through. So it's important that they can be flexible and deformed to fold over and get through the capillaries. Babesia infections affect the blood cell membranes and make them less deformable. So it causes sludging in the microvasculature. And that's thought to be one of the reasons why there's air hunger and cognitive dysfunction, other organ dysfunction. In addition to this, because of the activation of the adhesins and activation of the fibrin cascade, microvascular occlusion and even local clots and ischemia can result. Now, as if that's not bad enough, it can also affect the mitochondrial function of the host. Sick mitochondria lead to not just fatigue and tissue damage and tissue stress, but impaired immunity and impaired parasite killing. So you have several forks in this this parasite host battle. Now, when red cells get destroyed, you find fever, can be anemia, can be low grade or can be sudden, jaundice and hemoglobinemia, hemoglobinuria, metabolic acidosis, and also in low grade infections, there can be unexplained iron deficiency. Now, I've had patients in my practice who didn't know they had Babesia, but they had unexplained iron deficiency, worked up for GI blood loss and other things, and they just kept losing blood. And apparently, you can stain the urine for hemosiderin as one of the most sensitive ways to look for low-grade hemolysis. And Babesia can cause that, even in a subclinical infection. Can be transmitted by transfusion. I was kind of surprised to find it's the #1 most commonly transmitted pathogen in red cell transfusions, and can be packed fresh red cells, frozen red cells, and even platelet concentrates derived from whole blood. And maybe that's why cases occur in non-endemic areas, but looking at the maps I showed you, I don't know what is a non-endemic area at this point. In general, people who receive Babesia from transfusions manifest within the first month, can be as brief as a week, maybe as late as 9 weeks, but usually around a month into it where they get typical Babesia symptoms. Can also be transmitted through pregnancy. Cases of congenital Babesia were detected usually between 3 to 4, maybe 5 weeks after birth. What happens can vary, can be asymptomatic for the mother. The mother can have fever. There's a syndrome called HELP, hemolysis, elevated liver enzyme, low platelets, HELP syndrome, which can be caused by Babesia, among other things. Neonates can get hemolytic anemia. They can get thrombocytopenia. And in the articles that I've read, all infants in these series required blood transfusion. That's how severe their anemia was. So it's a problem. It's very important. Now, if the person's sick enough to be hospitalized, it's a whole different thing. Most of our patients are not hospitalized, but there are some who have, and I've seen them myself. And the most common manifestation is acute respiratory distress syndrome and DIC, disseminated intravascular coagulation. The acute hemolysis can occur and result in sudden anemia with fatalities. In fact, I had a patient who, elderly man in his 80s, frail, came to the hospital in the afternoon with a fever, was ill. Overnight, he hemolyzed suddenly. His hemoglobin went down to 5.5. It was so low, in fact, he had an acute infarct, ended up with a massive infarction. But we were able to get the Babesia under control, and the cardiologist worked on his cardiac conditions, and he survived. But it was very scary. In a matter of a few hours, he went from a normal admission hemoglobin about, I think it was 13, went down to 5. So think about this. If you have these really sick patients, crazy things can happen very quickly. There have been reports of congestive heart failure, coma, liver failure, renal failure, even splenic rupture, all depending on host-parasite relationship and how sick the patient is. And again, these are hospitalized patients, but there have been fatalities anywhere from 6 to 21%. The higher rates are those who have immune suppression or asplenic and so forth. So it can be severe. Well, what are the clinical clues? One thing is that this is one of the tick-borne diseases, just like the rickettsias, that can cause an abrupt onset of initial illness. Doesn't have to be, but it can be. So if someone has been tick exposed and they come by or develop a few days, a week or so later, a sudden fever and illness and so forth, you have to think of Babesia in the differential. Another very important thing is sweats, especially at night, day sweats and night sweats that are real. It's not just a little clamminess, but real sweats. Fatigue can be very profound, more than with straight Borrelia infections. Another peculiar thing is air hunger. People feel like they need to take a deep breath all the time. They're just not getting air. They could be short of breath just speaking on the phone. Related to that is the unexplained dry cough, probably again due to the sludging in the capillaries. The headaches you get with Babesia are global and migraine-like in the sense of photophobia involving the whole head. Interestingly, they can respond to the tripans, sumatriptan, and other migraine-like medications. So that's another clue. Someone with ongoing migraine for no apparent reason, think about that. Again, probably because of the vascular compromise, there's a strange feeling of being off balance, like someone's going to tip over forward or backwards or sideways. Big problem with stairs. No vertigo with this. It's just this tippy, strange off balance feeling. Babesia duncani is known for a more severe infection than microti. Usually those, not usually, but often, they're involved with anxiety and GI distress, not always, but often. As a group, the Babesia infections do cause hypercoagulation, and I showed you the mechanisms for that. Interestingly, the patients respond to heparin. A lot of clinicians have their Babesia patients on low-dose heparin or heparin derivatives, and that gives them symptom relief and might actually help in the clearing of the infection. We're not sure, but it seems to work clinically. And again, a clue that we always talk about, if you have a Lyme patient when the symptoms are way severe and the treatment is not running too well for the patient, you have to think of Babesia, because aside from the fact you have another infection to deal with, somehow the Babesia makes the Lyme more severe. As I was kind of hinting at, this presentation can vary, can be very mild to the point of being either asymptomatic or just missed, or can progress to a obvious illness or severe illness, even a multi-organ failure, even fatality, as I mentioned. Usually the severe presentations are in the elderly, those with real immune compromised status, and those who don't have a spleen especially. I've seen the asplenic Babesia patients, and they get sick really quickly, and they're very hard to control. But, you know, our chronic Lyme patients, chronically co-infected patients, often have immune suppression, so don't be surprised if Babesia becomes severe in them as well. And as I mentioned, when Babesia is present in a Lyme patient, the Lyme symptoms are more severe, the Lyme is more treatment resistant. So if you have a Lyme patient that's really causing you gray hairs, think of Babesiosis, because that's a clue. Well, testing is difficult. Why is that? Well, parasites are present in the bloodstream during the initial infection at the highest rate, but they rapidly decrease as they get sequestered in the spleen and the microcirculation. Now, in the immunosuppressed, of course, the parasitemia can increase again. So direct testing, which we'll talk about, may have a role early in infection and later on. On the other hand, they're not always found in the bloodstream. They can be sequestered. So a direct test like a blood smear doesn't always work. How about doing antibody tests? Well, antibody levels are not always high enough to be detected. Again, they can be immune suppression, and that'll decrease antibody levels. It's also the problem of immune complexes. When we have antigens like these Babesia in the bloodstream, the body makes antibodies, and they come together as immune complexes. If there's antigen excess, more parasites than immunity at that point, all the free antibody gets complexed and is no longer free to be detected by serologies. So that's the paradox we see in all the tick-borne diseases. The sicker patients are usually the ones who are seronegative, and likewise, as they get treated and start to feel better, as the antigen load goes down, now you have some freed up antibodies, and they can paradoxically go from seronegative to seropositive as they actually get better. We see this in Babesia as well. Another problem with testing is that multiple Babesia species may be infecting the patients, and not every test is validated for them. And there are at least 13 pathogenic species seen in humans, including some non-human parasites seen in the immunocompromised. So you have to have a broad testing palette to look for all these. So we'll talk first about the direct testing. The stain smear that's done in hospitalized patients is a Giemsa stain. It's just like what they do for looking at differential counts. It's only useful within the first week of infection. Literature says first 1 to 2 weeks, but I don't believe that, because in my experience, after the first week, they usually disappear. And the way you can determine how accurate the test is or how sensitive it is by what's called the limit of detection. Hospitalized patients often have a parasite load of usually 1, 2, or 3 per 100 cells per high-powered field. So like a 3 per 100 is like a 3% infection rate. When you get down to 1 or 0.5%, in other words, 1 for every 200 cells, that's about as low as you can go on the limit. A less plentiful parasitemia at that point, you really can't see on the standard smear. What you do then is what's called a FISH, a fluorescent in situ hybridization assay. What they do, it's the same blood type of smear, but instead they use a specific dye. It's a fluorescent dye that binds to the RNA of the Babesia. And because it's fluorescent, you can see much better result. You can find them in much easier than you can with the Giemsa smear. I'll show you pictures of that. They also can detect organisms stuck in biofilms. The Eugenics FISH assay is a genus level test, so it's broad coverage for a lot of different species. In terms of limit of detection, published reports show it not 0.5%, but 0.001%. So it's many orders of magnitude more sensitive than a direct smear. Now, despite genus level detection, the number of atypical Babesia out there and some of the atypicals can still be missed. This is just a similar comparison, a game sustain versus the fish. I'm going to use a pointer. See in the far left, these are game sustains, and these are infected red cells. And it's very impossible to say, well, these might be platelets that are overlying it. This might be an atypical white cell. We don't really know what that is. I mean, it's not always that specific, but with a fish test, because this is an RNA-specific probe, you can see it lit up. And these are different microti, dincani, divergens, bigemina, bovis, different ones have shown up on fish. And here's another one. It shows that the probe can be species-specific or genus-specific. And all this basically shows is that the genus-specific test, the genus-level test that is offered at Genetics does pick up all these different species. So that's why that's done. Another direct test is the PCR. The results, as I mentioned briefly with talking about Oticoliae, depends on which DNA primer set you're using. And sometimes you pick them up, sometimes you don't. Can be genus or species specific, but overall sensitivity is poor. The other direct test that's being used more now is the culture. Culturing is always the gold standard of infectious diseases. And being a direct test, a positive test, simply shows that the person was infected the day the blood was drawn. So that's really, really useful. This is available through Genetics. They call it a CE-PCR, culture enhanced PCR. Again, it's genus level. So it's detecting not just the main microti dincani, but others as well. In fact, it's so sensitive they picked up some strange things. I'll show you this. Chronic fatigue patient, sick for a number of years, all the typical tick-borne disease testing was done, couldn't find anything. So diagnosed with chronic fatigue syndrome. Well, they did a Babesia culture in this patient, and they came up with a germ called Culpadella. It's a parasite that doesn't normally live in people, lives in soil and in pond water. Occasionally it can be found in animals. And there are 2 cases reported of human infection. And they found this using the culture in a chronic fatigue patient. So they didn't, of course, believe it. And they had it sequenced and didn't believe it. So they took another sample, sequenced that. And again, it was true. So here we have the culture being so sensitive, it's picking up things that you would never otherwise expect. When we talk about the numbers, doing serial PCRs or serial dilutions on the culture show that this is more sensitive than standard PCR without a culture by at least a factor of 10. And I've looked at the raw numbers, it's more like a factor of 100, but it's at least a factor of 10. When they validated this, they sent every single positive culture to an outside lab for sequencing. 100% of the time, the sequencing matched the initial culture PCR. And also they did reverse Western blots to prove that what was actually in there was really growing Babesia. In fact, it was 100% of the time. All right, so they're indirect tests. We'll talk first about serologies. This measures the antibodies. They appear later, but they may remain negative. Again, because of immune suppression or because it just bound up in immune complexes and aren't any free to be detected. When you talk about what I call standard serologies, IFAs, ELISAs, the microwell tests, the vibrant chips, all those, there are 2 different sources of antigen that they use. Basically, the test puts an antigen in the system, and if there's antibodies in the blood sample that's put in, they'll bind together and cause either fluorescence or to light up or a signal electrically. So you need an antigen source to let this whole thing work. You can do one of 2 things. You can use a whole cell that you lyse to get all the different antigens out there, or you can choose single antigens, either recombinant or purified, to use in the testing. Well, if you use a whole cell lysate, so many antigens come out, they can be very nonspecific. They can be for other organisms, from even autoimmune disease. And that's why the specificity of whole cell lysates is very, very poor. You get a lot of false positives. If you use single or just a few of single antigens, not every Babesia is going to express every antigen. And so you can get a lot of missed samples, and there you get a poor sensitivity. So these type of what I call standard serologies, that's why I put in quotes, I really don't recommend you use them. What's being used now is what's called a multiplex recombinant technology. What they do, and this is the immunoblot from IGeneX, the antigens are not from grown organisms in culture. What they do, they use pure lab-created recombinant proteins where they can specifically choose which protein they want to use as the antigen. And what they have chosen is multiple protein antigens from each species, and multiple species are also included in each immunoblot. So that allows them to detect a broad array of species and more of the individual species despite variations that can occur. The result will show if microti and Duncani are present, they'll say, Duncani positive, microti positive. If other species are present, you'll see reported as genus positive. So if you see negative microti, negative Duncani, but genus positive, doesn't mean it's a negative test. It means they found something there that may or may not be Duncani and microti. Now, there are two reasons for a genus positive test. One is you have a species other than these two, or you have multiple species present, and there are co-infections of multiple species of Babesia. What happens is you get so many bands on the immunoblot that you just can't separate them out. And actually, in the lab's experience, the genus positives usually mean a co-infection with more than one species. But the thing about the immunoblot is it's very, very sensitive, so you can use it for early and late stage and basically disseminate disease. So it's good. It's more sensitive and more specific than the standard serologies because of the recombinant methodology. Here's just a quick slide on specificity. They took samples that are known to be positive for other tick-borne diseases, and there was no cross-reactivity. It picked it out 100% of the time. And in terms of sensitivity, this is an interesting slide. I want to show you this. These are the samples that were positive, okay? Out of the 63 positive samples, 45 were due to microti and Duncani. So what were the other 18? Were they just a combination of these two and you get too many bands to know, or was it some other thing? Was it divergens? Was it otocolii? Don't know. But it just shows you that there are a lot of other species out there. And it's, out of 63, that's 18 out of 63. That's not an insignificant number. So that's why this immunoblot is so important, because you're picking things up that you otherwise would not see on standard testing. So when it comes to testing, no single test is 100% sensitive. And therefore, what we've all had to do is order a combination of different test methods. You do the FISH for a direct test immunoblot because you want to get a broad serologic coverage, and a culture because you can pick up strange things that you don't otherwise see. Acute infections always favor a local direct test, such as a standard smear if it's a hospitalized patient, or the FISH. Culture definitely is useful then. Chronic cases, they can be immunosuppressant, there can be lower parasitemia. So you really, especially here, need to do a combination of tests, at least two, if not all three. Now I'm going to talk about treatment. Unfortunately, as bad as it is for Lyme disease, it's even worse for Babesia in the sense that there's very little useful research on treatment protocols. There are a few in vitro studies, a couple of animal studies with herbals, some case reports, but really no relevant clinical trials, none at all. So what that has resulted in are treatment regimens that are really based on malaria experience. So what are that? Antimalarials alone or combined with antibiotics, antiparasitics, botanicals, any of these together or separately. That exchange transfusions have been used. They're only used for the really severely ill patients, those hospitalized with very high parasite load. The standard that they use nowadays is greater than 10% red cell infection rate. But this is not curative. It just serves to rapidly decrease the parasitemia, and then the patients have to be treated with one of the medication regimens. So the basics. The problem is that drug resistance has been reported. So therefore, it's kind of standard to use a combination of prescription medications. Common nowadays to add the botanicals, and I'll give you a list of those. It's also known that atovaquone resistance is now being seen more and more. And resistance is a relative one. If you're able to push the dose higher and the patients can tolerate the higher dose, they can overcome atovaquone resistance. The duration of treatment is not standardized. Some people say treat for 10 days in an acute case. I don't believe that, but that's what you can see in the literature. Some cases are so chronic and so treatment resistant that the patients have to be on long-term suppressive therapy. But the typical treatment regimen runs 4 to 6 months in the typical co-infected tick-borne disease patient with babesiosis. And just like with Lyme disease, there's no test that will track the progress. There's no test for cure, so it's all clinical. And unfortunately, relapses are often noted. Some cases have been reported relapses 2 years later. Person was treated for Babesia, seemed to have a recovery, did well, but then something hit the immune system, chemotherapy, a bad infection, so forth, steroid use, and bam, the Babesia comes back. So relapses are possible. I'm going to give you a list of medications that are being used. Start with clindamycin and quinine. That was the originally recommended regimen when this parasite would start to become recognized. Very difficult to tolerate. The dropout rate in the series have been as high as 40 or 50% because of side effects. And despite that, there have been many treatment failures. So this is really no longer the first choice. Atovaquone plus azithromycin is the currently recommended regimen to start with. The problem with this is that atovaquone is very poorly absorbed. So there are several tricks. Number one, has to be taken with food, otherwise it won't be absorbed. Number two, the food has to have a reasonable fat content because it's fat soluble. This is much better tolerated than clindamycin quinine, but as I said, there are cases of resistance appearing. Babesia duncani is especially resistant to this regimen, and again, here you have to consider pushing the dose. Another combination is the atovaquone proguanil combination tablet. The brand name on that is called Malarone. The problem here is that it's got poor absorbability. Atovaquone is a liquid because they found liquid absorbs better than solid, and the atovaquone in a solid pill form has even less good absorption. Absorption rate is almost half of that of the liquid. So you get poor blood levels. There's a risk for treatment failure and drug resistance. So it's really not a good choice. And I usually stay away from that if I can avoid it. So let's talk about a basic starting regimen. It's atovaquone 750 twice a day with food, fatty food, azithromycin 500 milligrams a day, either orally or IV, plus an artemisinin compound. As I mentioned, you may have to double the dose of atovaquone, but notice that high blood levels can cause the patients to develop a vision effect where everything starts to get a yellow tinge if they see it. I was once treated with this and I got yellow vision, as did my son. So it's a real thing. If that happens, it's not permanent. It's not, it's just temporary, but it's scary and you don't want that to happen. So you're gonna have to back off on the dosing of it. If this is the basic regimen, you can either substitute or add the atovaquone proguanil combination to get the proguanil in it. If you're going to use this tablet, this combination tablet alone, you want to push the dose to 750 milligram equivalent, which is 3 tablets twice a day. But then that means the proguanil component might be too high. So you have to start monitoring liver enzymes, renal function tests, blood counts, look out for side effects, so forth. So that's really not always recommended. It's been found that adding trimethoprim, sulfamethoxazole, or metronidazole to the basic regimen can potentiate the primary therapy. And that's been used quite frequently. What about the others? The artemether lumefantrine combination is called Coartem. It's usually given for malaria as a single pulse of several days. In Babesia, what a lot of clinicians are doing, they're giving weekly pulses, 1 week on, 1 week off for 2, 3, sometimes 4. Again, you have to watch for side effects. Especially look for the QT interval. Prolongation of that is a possibility, actually, with any of the quinine-based drugs. Always recommend to do a baseline cardiogram to measure the QT. And if there's, a borderline level, or if you're just really concerned, especially in young children, especially females, you may need to redo the cardiogram once they're on it to make sure that the QT interval did not get prolonged to a dangerous level. Also, there's disulfiram, known as antabuse. Published reports of efficacy in treating Lyme and Babesia co-infected patients, but it's a very tricky, touchy regimen to do, and you have to be familiar with the subtleties. You have to start very, very low. It's very kindling to the autonomic nervous system and can cause a lot of trouble if you start with too high of a dose. And we're talking about sometimes half a tablet every 3 days to begin with. Dane Kindler is a physician who's very experienced with this, and he's written up a protocol, which you can find on the internet, no doubt. And if you're going to use disulfiram, I recommend you get very familiar with how to use it, because you don't want the serious side effects. And this is disulfiram. It causes antabuse-like effects because it is antabuse. So you have to be careful of herbals that are alcohol-based, or high yeast loads in the GI tract where carbohydrates can be fermented into alcohols. So again, a very touchy medication. And that's actually a reverse trick. If you have someone on disulfiram who has all the antabuse type reactions with no other obvious alcohol intake, think that they might have candida in the GI tract and they're fermenting their carbohydrate meal. Mefloquine, also known as Lariam, has been used. This is an antimalarial that has a lot of scary neurologic side effects, including psychiatric side effects, which can persist after treatment ends and even become permanent, including some very scary hallucination type behavior, depression, even suicides have happened. And just so you know, there have been a number of lawsuits because of the use of this in malaria. So basically, I don't recommend it if you have another alternative. Now, tefenoquine is something that's come on the scene fairly recently. They found that in vitro and animal data is quite encouraging. And there's some case reports now out there where it's been used in patients as well. The mode of action is not really clear. They think that what it does is involves oxidative damage to the Babesia organelles. It's very oxidating type of treatment. And because of that, you have to check the patient's G6PD status ahead of time. And if it's G6PD deficient, you can't give it. The studies have shown that if this is given as a single agent, it doesn't cure the patient. The parasite load goes down, but it doesn't go away. So this is kind of typical of this treatment in general. However, when artemisinin compounds were added, there was synergy and they got some cures. They say to watch for hyperkalemia. I have not seen that, but they say to watch for it. Nobody knows the dosing. I'll just give you this as an example of what some are doing. Note it has a long half-life, so they gave a loading dose. In this example, they give the 100 milligram tablets 2 at a time, once a day for 3 days as a loading dose, and 2 taken together once a week for at least 6 weeks. This is just a rough example of what some are doing. You can get 150 milligram tablets. Nowadays, it's hard to get. Some drugstores are out of it. I see it's coming back. You know, one of the problems of modern medicine, I guess. But again, I'm showing you the dosage just as a generalized example of what's being done out there. But there are problems with treatment, okay? First of all the currently recognized regimens are based on malaria protocols. We don't have clinical studies of any value on true Babesia patients, okay? What about the quinine drugs? Guess what? Quinine drugs, as used for malaria, are targeting organelles in malaria that are not present in Babesia. Here's the fine print. In malaria, they have a digestive vacuole, and in that vacuole, when quinine drugs are given, hemoglobin is degraded. It's forming free protoporphyrin that inhibits parasite growth and disrupts hemozoin formation, okay? However, Babesia don't have digestive vacuoles, they don't degrade hemoglobin, and they don't produce hemozoin. So how do the quinine drugs work? I mean, they're not ineffective for Babesia, they do work to some degree. Well, the thinking is that it's probably oxidative stress, just like with tefenoquine, which is a quinine base. So that's the thinking with the quinine-based drug. It's oxidative stress to the organelles. The atovaquone, that targets a different area. That targets the cytochrome chain. And the resistance you get with atovaquone is because of mutations in cytochrome B, where it becomes relatively resistant. It's not a total resistance, and that's why pushing the dose, if possible, can overcome it. You can see resistance to azithromycin. It does target the ribosomes. Some people say, well, instead of azithro, I'll use clindamycin. Turns out they target the same RNA ribosome. So if you're resistant to azithromycin, likely you are resistant to clindamycin as well. But again, these drugs have worked. So there are unknown reasons why they're working. And again, we think it's oxidative, or they think it's oxidative stress. So the approach is to maximize the dose within reasonable safety limits, use combinations that have been known to work, and monitor your patient carefully. Let's talk about combination therapy. The goal of combination therapy is to prevent the development of drug resistance and to broaden the coverage. Again, we have a lot of different species potentially out there. So we're talking about atovaquone liquid plus azithromycin plus artemisinin, atovaquone proguanil, artemisinin with it, artemether, lumefantrine, which is already a combination. Again, the weekly cycle is the week you're off of that. Artemisinin is often given. Mefloquine plus artemisinin, clindamycin, quinine, artemisinin, not good toleration. Adding sulmethoxazole, trimethoprim, and or metronidazole can be added. All these things are being tried with variable degrees of success in individual patient. The regular, not terribly sick Lyme Babesia patient will respond to these regimens. The more sick ones usually will not. Herbals and botanicals, that's getting more attention lately, and they are now routinely being added. The number of recently published studies have demonstrated results that are excellent in Babesia using culture systems. Cryptolepis, Artemisia annua, which is sweet wormwood, Chinese skullcap, Japanese knotweed, Alchlormia. These have been shown to actually have bactericidal effects at levels that you can achieve in the bloodstream with typical dosing of these herbs. Other botanicals have been used. Interestingly, high dose vitamin C has demonstrated inhibitory effects and may be useful as an adjunct. Now, low dose vitamin C is an antioxidant. High dose is oxidative, just like the quinine drugs. So maybe there's a trend here we're seeing. So if botanicals are used, the authors have recommended a combination of at least 2 at a time, either by themselves or with prescription medications. And, a number of different companies, such as Beyond Balance, Research Nutritionals, Burr & White, they have their own formulas for Babesia, and they are combinations of these plus others that they found to be helpful. So have the clinicians. But the idea is that you want to have combinations to broaden the coverage, to prevent drug resistance, and just to do a better job. So at this point, in addition to the prescription drugs, adding botanicals is really definitely recommended. But there's a caveat to this. The botanicals are mixtures of different plant-based chemicals, obviously, and the better botanicals are often mixtures of the whole plant extract. That's thought in Chinese medicine to be more effective, but that also means you have a lot of compounds that you really can't monitor. You really don't know what exactly they are or what they're doing. So these patients really have to be monitored for lab abnormalities and potential drug interactions. Okay, so botanicals, I think, are important, and I think they're really needed, especially in the sicker patient. But really be careful with these patients for drug interactions and lab follow-up. And some cautions, though, with supplements. As I mentioned, atovaquone, it targets the electron transport chain. So it's been recommended that supplements such as CoQ10 and NADH that are used to support the electron transport chain may inhibit the effect of atovaquone. So it's long been recommended not to use CoQ10 and nowadays also NADH supplements when someone's on atovaquone. Are there published studies? No. This is just kind of based on intuition, common sense studies, studying the metabolic pathways. But that's actually what the thinking is nowadays. As I mentioned, tefenoquine kills Babesia by oxidizing the organelles, or at least that's what they think, as with all the other quinine type drugs. So some advise stopping all the antioxidants while on this medication. Again, oxidative therapies like high dose vitamin C may be promising for this. Okay, I don't have any literature on ozonation and other oxidative therapies, but the clinicians out there who've used it have found it to be useful. So back to my last slide, which is great because it gives us time for questions and answers. So basically, as I've shown you, Babesia is a common co-infection in Lyme patients, maybe the most common depending on where you live. Evidence is suggesting a broader array of species may be infecting the patients, and that has implications for diagnosis, lab testing, and maybe treatment too. Now, symptoms may be nonspecific, but symptom patterns may be helpful. Again, looking for the sweats, the air hunger, the dry cough, the strange migraine-like headaches that respond to migraine medications, this off-balance feeling without vertigo. Those are things you don't often see in Borrelia or Bartonella, but you do see in Babesia. Likewise, you don't see arthritis in Babesia. So that's another differential point. Because of the different species out there, and because no one test is 100%, the testing strategy really does support combining multiple methods for your patients who are more of a problem in diagnosis. Treatments are universally not successful, but progress is being made, and basically you need to become familiar with the different medications out there, their track record, how to use them, and how to logically combine them. It doesn't make sense to use only antioxidant or oxidative therapies. It doesn't make sense to use only cytochrome therapies. It makes sense to use a combination of things that hit oxidation, that hit ribosomes, that hit the cytochromes. Make it a broad coverage, get some herbals in there too. And as I said, there's a lot of published evidence that supports the use of botanicals. So that was my last slide. I want to show you just beyond this, I have a number of pages of references, so you can refer to these if you need to read more and maybe to support what you're doing clinically. So I'm going to stop here and open it up for Q&A, and we'll let our host talk about that. I'll stop sharing the screen. And here we are.
Awesome. Great job. Thank you, Dr. Barisano. I have a bunch of questions already received in the Q&A section. Just to reiterate briefly for people, I see a couple of the questions do ask, will there be notes and or a copy of this recording? Yes, it's being recorded. Everybody who is signed up will receive a direct link first thing tomorrow morning, as well as a copy of the slides CC'd on that email. So no worries about that. You'll definitely have an opportunity to review. I know Dr. Burrascano gets really in depth with a lot of these, so sometimes it takes more than one time watching to get all of the information. So with that being said, let me go ahead and jump into some of the questions. I know they may have been initially posed earlier and you may have covered the information after, but I'll just go ahead and ask them anyway.
Okay.
So the first is, can blood products and derivatives like IVIG contain Babesia?
The only things that have been shown to contain Babesia are blood products that are either fresh or frozen, such as fresh frozen platelets, frozen red cells, packed red cells. But refined blood products like factors and immune globulins, no, they're not present at all.
Awesome. That was a straightforward and easy one. Let's see. Some of these.
I hope they're all that way.
Yeah, exactly. So some of these, I'm not exactly sure how they may apply, but I will still ask because they've been placed in the chat. This one is, what do you think about hyperbaric oxygen therapy for patients with Babesia? I understand that Babesia and Bartonella are aerobic bacteria. Can hyperbaric oxygen make the condition worse instead of helping?
I really would doubt they would make it worse, but there probably is some benefit to the end organs that might be starved because of the poor circulation. So it might not be therapeutic in the sense of killing Babesia. I don't think it would make Babesia worse, but it might be therapeutic in relieving end organ damage and giving the patient some relief. And that might be important for some of the sicker patients where treatment is going to be prolonged and difficult and not give them an instant result. So here, the supportive effect of hyperbaric oxygen might be worthwhile. I'm not aware of studies. Again, there are very few, if any, studies on this in Babesia. So I have to give that as a caveat. But just logically thinking it out, I think it has a role.
This person said, and this is kind of a two-part question. I believe they asked both. The first is, can Babesia cause acute burning pain throughout the body? Basically, they said like the blood feels like acid.
You know, it's probably a reflection. It's called RSV, RSC, reflex sympathetic dystrophy, and it's probably a central pain origin due to microvascular changes and maybe toxic effects in the nervous system. So while that's not listed as a regular Babesia type of symptom, I've had Babesia patients with really strange pain syndromes, and it usually goes along with the encephalopathy from it. So I can't say directly yes, but I have seen that type of strange thing, yeah.
Well, an immediate follow-up to that is the heart palpitations. Can it be caused by Babesia? Or if you are feeling symptoms of that, is it likely from another co-infection?
Well, this applies to this question and the previous one. Babesia makes other co-infections worse. And we know that with Lyme disease, we know that probably is going to allow some latent viruses to reactivate. So whether Babesia itself is affecting the heart directly or not may not be relevant. It may be that other things are there that will affect the heart more directly. I'm not aware of any studies showing Babesia in cardiac tissues. Of course, there are many studies showing Borrelia in cardiac tissues. But again, there are studies showing Babesia causing microvascular problems. And that could be a double-edged sword for the heart. You have poor circulation and inflamed, infected heart. I mean, I could see it. No one's going to biopsy your heart to be sure. But that's why I want to get some good testing done and get on a logical treatment regimen.
Well, this is a good segue then, since you mentioned testing. Somebody asked, what do you do if you have a positive immunoblot IgM test for Babesia, but a negative PCR? Do you still treat?
If the symptoms support it, then you do, yes.
Yeah, definitely a clinical diagnosis. I've heard that response across a range of webinars I've hosted.
Well, you know, before we had the culture, the only direct tests we had were FISH, which is pretty good, and the PCR. And notoriously, the PCR was very insensitive. I mean, 20% pickup rate is considered good. We're talking about sometimes single digits, sometimes 13%. And that's good quality PCRs. It's just because the parasites, they sequester. They don't often come into the circulation. So that's why you do need to do a better direct test like a FISH and a culture, but also definitely do the immunoblots because you need to look at the whole spectrum of what's going on. Also important, if you have, let's say, a positive culture and a negative immunoblot, that implies that there's something wrong with the immune response. Either there's an overwhelming infection and the antibodies are bound up in immune complexes, or you have a very weakened immune system. And that's a clue, then you want to do an immune workup. That's one more reason why you want to combine tests, because it gives you subtle clues that you don't otherwise find.
So I am seeing more questions coming in. It seems like some of them are moving a bit away from the topic of Babesia, but this one seems to be relevant to the conversation as a whole. This person asked, how can you tell if a patient is responding to a short-term regimen so that you don't necessarily have to treat them for 4 to 6 months?
The 4 to 6 month thing I originated because, they're red cell parasites. And if you're on treatment and you're getting the red cells sterilized, Babesia are also in the bone marrow too. And you want to make sure that the red cells and the precursors that are infected are sterilized. And the lifespan of the red cells is 120 days. So you want to have coverage for the whole cycle of a whole new generation of red cells. So it's kind of logical. Clinically, I mean, we get these clinical studies done, but our impressions from my patients support 4 to 6 months of treatment. And so that's where that comes from. Shorter treatments, if it's something that really works well, then perhaps that's great. But if you see that, tabulate it, let us know.
I'm seeing a lot of questions here about specific treatments. I'm not sure, how much time we have. I'm probably going to look to end this around 6:30. So I guess my main thing would be there's a couple of line items here. SOT, methylene blue, hyperthermia, hyperthermia. Like all of these are just generalized. Would you utilize it to treat Babesia? I guess the better question, given all of these, is there any of those that you wouldn't necessarily utilize or that you would say to stay away from when looking to treat?
We'll start with SOT therapy. SOT is very specific to the organism, and the problem is that there are probably more than one type of organism. And I say that because they found Babesia will exchange DNA with each other, just like Borrelia do. And you can have these like intermediate strains, maybe the same species, but the strains vary. So one of the concerns with SOT is that it's not broad enough to cover all the different organisms you have. And there are case reports of people say, we use SOT and it worked great, I felt great. Others say it didn't do anything for me. And that's probably because we don't yet have a handle on the broad range of what's going on. So that's at this point hit or miss. So leave that up to the individual patients, and doctors have their good discussion and decide what to do. I'm not aware of hyperthermia helping. It probably would make you worse because Babesia does cause microcirculation problems, and that's the last thing you want to have when you're trying to vasodilate and perfuse your body. So I would stay away from that, but that's just me saying it. I don't have experience with it though, so that's all I can say. Hyperbaric, like I said, probably is very supportive. I don't think it's curative, but I think it's very supportive. And in terms of the herbals and the botanicals and the vitamin C's of the world, that's been used for years by the naturopaths, and they were right. And now we have published studies to support that, especially since the prescription drugs don't do so well. But I don't think in the sickest patients, the botanicals alone are enough. I think you need to use all of them. I think it's reasonable to have someone on prescription and botanicals together, and when the infection seems to be controlled, you can stop the prescription drugs, but continue the botanicals more or less as maintenance therapy to be sure there's no relapse happening. A lot of people do that, and I think that's valid also.
So I will also use this opportunity to plug our website. I see a lot of questions, like I said, ozone therapy, SOT, a lot of these alternative emerging treatment methods we have information on in our news and blogs section, which I just put in the chat. If you use the search bar up top, you can find exactly what you're looking for. It's our So You're Considering series. We did this across social media and our website. So please, I ask you to check it out, because as Dr. Babesia mentioned, a lot of these don't necessarily have published research specifically relating to Babesia. So it's something to give you a bunch of background research as to what is the origination of the treatment, maybe where was it, like how is it being utilized when it first came out? How has it evolved to be utilized for tick-borne disease? And what I would recommend you all do is read through that and take the information back to talk with your provider, because that would likely be a best way for you to move through this without necessarily taking too much time. I did just receive a text from somebody who was on the chat about the hydroxychloroquine. I guess they were interested in learning a bit more about it. Would you recommend it or utilize it with Babesia specifically?
There are case reports of it working, but very few and far between, but it has been used as long-term suppressive therapy. So again, I don't think there's a very high Babesia load and a very high degree of illness that it would be a primary choice. If you're taking it because of some other condition and you have Babesia with it, well, that might not be a bad combination to use as part of the therapy. I want to go back to that last thing you were talking about, the different methods of treatment. You know, when you choose a method of treatment, a complementary alternative method of treatment, part of it has to do obviously with it. Will it work? Is it dangerous? Whatever. The other part has to do with the practitioner's experience. Some practitioners are very experienced in one more so than another, and they favor it because they have experience with it. And that's a valid thing to do. If someone's never used hyperbaric therapy and says, let's do hyperbaric, well, that's not so great. If you have someone who's experienced with it, they know the subtleties, and then they might favor that. If someone doesn't do that, someone uses oxidative therapies, you know, they might favor that, whereas someone who doesn't do it. You want to go to a clinician who has experience with what they recommend. You don't want to be the first one in the line.
Yeah, I think that makes a lot of sense. And that's really why I recommended at least reading some more information. That's why we've worked to compile as many of the therapies we've heard kind of emerging in the space and people have asked questions about. Clearly, it's of interest to even people on this webinar. So definitely check out our website. I think really out of all the questions, that was all the ones that specifically relate to this presentation. So thank you everybody for attending. Thank you for submitting your questions. Some of the people did utilize the Q&A space to say, thank you so much, Dr. Burrascano. So I will relay that to you. Thank you so much, as always, for being a great presenter and bringing a wealth of information to the table. Again, for everyone, this is being recorded and it will be sent around tomorrow morning. So you'll have the link to the slides, the link to the video, so you can review again. Everybody have a great rest of your night. And thanks again, Dr. Burrascano.
Good night, everyone. Thank you for being here.
All right. Bye-bye.